Thank you, Dr. Ajay. Good morning, ladies and gentlemen. I am thankful to chairpersons for giving me this opportunity to deliver this talk on management of hepatic encephalopathy. The most important step in management of hepatic encephalopathy is control of identification and correction of precipitating factors like GI bleed, infections, spontaneous bacterial peritonitis, excessive proteins in diet, and use of sedatives and other drugs. Drugs which have been tried in treatment of hepatic encephalopathy are inhibitors of ammonia production and absorption, and drugs enhancing metabolic removal of ammonia, reduction of false neurotransmitters, probiotics, anti-inflammatory drugs, and drugs which inhibit neural inflammation. Liver transplant and liver support systems have been tried, however, efficacy is doubtful. Various drugs have been tried, evaluated, which act at different pathogenetic mechanisms of hepatic encephalopathy. However, the commonly used drugs are lactulose and rifaximin. These drugs inhibit production as well as absorption of ammonia and also endotoxemia. Lactulose is used in dose of 30 or 60 ml per 3 times a day to maintain a stool frequency of 3 to 4 per day. And rifaximin is used in dose of 550 milligram twice a day, and both the drugs are used for 5 to 7 days in acute episode of hepatic encephalopathy. The other drugs which have been commonly used are L-ornithine L-aspartate, which enhances metabolic removal of ammonia and also thought to have some anti-inflammatory activity. With conventional treatment of hepatic encephalopathy, around 2/3 improve within 48 to 72 hours. 10% of patients take prolonged course for improvement because of unidentified precipitating factor or precipitating factor identified but cannot be corrected. Around 1/4 of patients of liver cirrhosis with ultrasound sodium have causes other than hepatic encephalopathy, that is neurological causes. Now, liver-related causes of non-recurring encephalopathy are progressive liver failure, spontaneous portosystemic shunts, and patient undergoing TIPS. Non-liver-related causes of non-recurring encephalopathy are structural lesions of brain, infections, alcohol-related causes, and electrolyte imbalance. Hyponatremia is an important precipitating factor for encephalopathy, and probability of developing hepatic encephalopathy is much higher when serum sodium is less than 135 milliequivalents per liter as compared to normal sodium levels. In various meta-analyses, it has been shown that lactulose is more effective than placebo in total resolution of hepatic encephalopathy. It not only leads to higher improvement, but also shortens time to resolution and hospital stay. However, there is no advantage of survival. Lactulose is very sweet, not tolerated by the patients, leads to various side effects like nausea, vomiting, abdominal distension, increased borborygmi, and diarrhea. Therefore, lactitol, which is less sweet, better tolerated, and has less side effects, have been tried. And in various randomized controlled trials and meta-analysis, it has been shown that lactitol is as effective as lactulose in the resolution of hepatic encephalopathy and has less side effects, better tolerated. Predictors of non-response to lactulose and lactitol are high MELD score, mean arterial pressure less than 79, and hyponatremia. Rifaximin has been compared with lactulose in 5 randomized controlled trials. In 3 trials, rifaximin and lactulose were equally effective, and in 2 trials, rifaximin was better than lactulose, improving mental status, EEG findings, and arterial ammonia levels. However, there were no difference in survival. Now, with using single drug in conventional therapy, hepatic encephalopathy improves in half of the patients. Nowadays, there are reports on evaluation of combination of drugs for treatment of hepatic encephalopathy, in which one ammonia-lowering agent is combined with other drugs having similar mechanism of action or different mechanism of actions like reduction of other neurotoxins, reduction of endotoxemia, and reduction of inflammation. It is thought that two drugs will have synergistic and additive effect and will be more effective in treatment of hepatic encephalopathy. In this double-blind randomized controlled trial, combination of rifaximin plus lactulose was compared with lactulose in treatment of hepatic encephalopathy. In this study, patients with advanced grades of hepatic encephalopathy were only included. It was found that resolution of encephalopathy occurred in 3/4 of patients treated with combination as compared to half of patients treated with only lactulose. Hospital stay was shorter and mortality was lower in patient treated with combination of rifaximin plus lactulose versus lactulose alone. Also, survival during hospital stay was better in patient treated with combination as compared to patient treated with lactulose alone. Albumin binds endotoxins, decreases inflammation, and prevents infections. In a double-blind randomized controlled trial, 120 patients were randomized to albumin plus lactulose versus lactulose alone, and patients were treated till recovery or maximum of 10 days. It was found that reversal of encephalopathy was seen in 3/4 of patients treated with albumin plus lactulose as compared to 50% of patients treated with lactulose alone. Also, there was shorter hospital stay and lower mortality. In addition, lower incidence of infections during hospital stay in patients treated with combination. In both the groups, there was significant reduction in arterial ammonia levels, TNF-alpha, interleukin-6, interleukin-18, and endotoxins. However, percent reduction or delta change in arterial ammonia levels was not different in two groups. It was similar. But percent reduction in TNF, interleukin-6, interleukin-18, and endotoxins was higher in combination group as compared to lactulose group alone. So this means that beneficial effects of albumin were not due to increased reduction in ammonia levels, but were due to its anti-inflammatory activity. Polyethylene glycol, as we know, is a cathartic, rapid gut clearance of bacteria, and inhibits ammonia production, other neurotoxins, decreases endotoxemia, and reduces systemic as well as neuroinflammation. In this randomized controlled trial, polyethylene glycol was compared with lactulose for treatment of hepatic encephalopathy, and results were evaluated at the end of 24 hours of treatment. And it was found that overall response within 24 hours was much higher with polyethylene glycol as compared to lactulose. And also, there was quicker resolution of encephalopathy in polyethylene group as compared to lactulose group. So the study concluded that polyethylene glycol improves hepatic encephalopathy faster than lactulose over first 24 hours. In this study from PGI Chandigarh, polyethylene glycol plus lactulose combination was compared with lactulose alone, and 60 cases were randomized to polyethylene glycol plus lactulose, and 31 patients in this were treated with lactulose standard medical treatment. In group 1, on day 1, patients were given 2 doses of polyethylene glycol 12 hours apart, and from day 2, only lactulose plus standard medical treatment was given, polyethylene glycol was not given. In group 2, whereas polyethylene glycol was not given at all, and from day 1 only lactulose plus standard medical treatment was given. And it was found that resolution of hepatic encephalopathy was much higher in polyethylene plus lactulose group as compared to lactulose alone. And also, resolution occurred at shorter period of time with shorter hospitalization time. 30 days survival was much higher in patient treated with combination as compared to lactulose alone. This is an important slide which shows there was significant reduction in arterial ammonia levels over 7 days in both the groups. However, percent reduction in ammonia levels and percent reduction in ammonia levels or delta change was similar. It was not different in two groups. So what the authors mean that beneficial effects of polyethylene glycol were not due to higher reduction in ammonia levels, but authors postulate that it could be due to reduction in production of other neurotoxins, endotoxemia, or maybe systemic or neural inflammation inhibition. L-ornithine aspartate is a mixture of two amino acids, provides glutamate to muscles, and therefore the substrate which should detoxify ammonia into glutamine. L-ornithine aspartate has been shown to reduce arterial ammonia levels and severity of hepatic encephalopathy. In various systemic reviews and meta-analysis, L-ornithine aspartate has been found to be effective in minimal hepatic encephalopathy, grade 1 or grade 2 hepatic encephalopathy. In this study, efficacy of intravenous L-ornithine aspartate plus lactulose was compared with lactulose alone in reversal of overt acute hepatic encephalopathy. This was a double-blind randomized controlled trial. It was found that reduction in ammonia levels, rate of recovery of encephalopathy, and hospital stay was much better in combination of L-ornithine aspartate plus lactulose group as compared to only lactulose group alone. Combination of 3 drugs has also been compared with combination of 2 drugs. In this double-blind randomized controlled trial, combination of L-ornithine aspartate, lactulose plus rifaximin was compared with combination of lactulose plus rifaximin alone. Patients with advanced grade, that is grade 3 and grade 4, were included in this study, and it was found that on day 5, the resolution of encephalopathy was much higher in 3 drugs combination group as compared to 2 drug combination group. And also, improvement in grade of encephalopathy was also higher in 3 drug group as compared to 2 drugs group. It shows that percent reduction in ammonia, interleukins, TNF-alpha, and endotoxins was higher in combination, with combination of lactulose plus rifaximin plus L-ornithine aspartate group as compared to placebo group. So this shows that beneficial effects of L-ornithine aspartate was not only due to higher reduction in ammonia levels, but was also due to reduction in endotoxemia and its anti-inflammatory activity. 30-day survival was much higher in 3 drugs group as compared to 2 drugs group. L-ornithine phenyl acetate is a drug similar to L-ornithine aspartate. Here, ornithine is converted to glutamate. Glutamate combines with ammonia to form glutamine, and phenyl acetate combines with glutamine to form phenylacetoglutamine, which is excreted in the urine. In experimental studies, it has been shown that these 2 drugs act these 2 compounds act synergistically and lead to sustained reduction in arterial ammonia levels, its brain metabolites, and brain water content. Recently, in a double, ornithine phenyl acetate plus lactulose combination has been compared with lactulose alone in a phase 2B double-blind randomized controlled trial. And in both the groups, patients were additionally given lactulose with the result rifaximin. And parameters studied were confirmed clinical response, time to resolution of hepatic encephalopathy, length of hospital stay, and adverse effects. And it was found that confirmed clinical response, adverse events, time to resolution of hepatic encephalopathy, and hospital stay were not different in 2 groups. These were similar. And it showed that in this study, hazard ratio of 1.25 and 95% confidence interval from 0.9 to 1.75 showed 25% increase in probability of confirmed clinical response in group treated with ornithine phenyl acetate. However, authors concluded finally that there are no significant difference in clinical improvement in 2 groups, and further studies are needed with better sample size. Role of liver support systems in chronic liver disease is limited, however, have been shown to reverse encephalopathy, but overall not beneficial. In this randomized controlled trial, extracorporeal albumin dialysis plus lactulose was compared with lactulose alone. And it was shown that mean cumulative number of improvements per patient were higher in albumin dialysis plus lactulose group as compared to lactulose alone. And also in albumin dialysis, response was higher and occurred at faster rate. Nutritional, patients need high calorie diet with protein of 1.2 to 1.45 grams per day. Earlier concept of protein restriction no longer exists. Various other modalities and drugs have been evaluated in clinical as well as experimental studies, which include fecal microbial transplant, naloxone, anti-inflammatory drugs, phosphatidylserine. However, these studies have limitations like presence of drawbacks in study design, sample size, safety profile. There is a bias in the studies and heterogeneity. So to conclude, ladies and gentlemen, disaccharides are still the first-line therapy of hepatic encephalopathy. Rifaximin is an alternative or an addition to disaccharides. Probiotics and L-ornithine aspartate are effective in minimal hepatic encephalopathy or low-grade encephalopathy. Combination of 2 or 3 drugs improve resolution of encephalopathy. Not only that, but also shortens the time to resolution, shortens hospital stay, and improves survival. And other than decreasing levels of ammonia at a higher level, it also has effects like reduction in level of other neurotoxic substances, reduces endotoxemia, and reduces inflammatory activity. Thank you, ladies and gentlemen, for your kind attention, please.